You're Dr. Bhavna, right? Yes, please come. So she's going to talk to us about superior oblique palsy, 10 things to learn from 10 cases.
Good morning, everyone. I'll be speaking on superior oblique palsy, lessons learned from 10 cases. Lesson number 1, most cases are congenital in origin. Congenital idiopathic are the most frequent etiologies. There's a history of early onset with facial asymmetry, long-standing head tilt with photographic evidence, large vertical fusional amplitudes, no diplopia, and lack of subjective symptoms of torsion. Lesson number 2 is the spread of cometance, which is seen in some long-standing cases where the hypertropia may be equal in the different positions of gaze because of contraction of the ipsilateral antagonist, the overaction of the contralateral yoke muscle, and secondary inhibitional palsy appears to be secondary inhibitional palsy of the contralateral antagonist. Lesson number 3, fundus extortion might not always be present in the paretic eye. Studies have found approximately 25% of patients with unilateral superior oblique palsy had excyclotorsion in the non-paretic eye due to fixation preference and neural adaptation. The paretic dominant eye could influence alignment of the non-paretic eye through conjugate cycloversion eye movements. So prolonged fixation with the paretic dominant eye might act to decrease extortion, which induces extortion in the non-paretic eye through the Hering's law. Lesson number 4, coexisting horizontal vertical deviation may be present in around 50% cases of superior oblique palsy. Horizontal deviation of 8 PD or more might need horizontal muscle surgery in addition to vertical muscle surgery. For example, in this case of a left congenital superior oblique palsy with inferior oblique overaction grade 3 and large angle alternating exotropia, he underwent horizontal muscle surgery in the form, he had 70 PD XT horizontal deviation, grade 3 inferior oblique overaction, and fundus extortion grade 2. The patient underwent supramaximal horizontal muscle surgery to tackle horizontal and vertical deviation in one go. So OSLR recession 12 mm, OSMR resec 7 mm, and OSIO recession 10 mm was done. At 2 years follow-up, this patient is ortho in primary position and OSI overaction has completely resolved. Lesson number 5, small horizontal deviations may self-correct with the vertical muscle surgery. So horizontal rectus muscle surgery is only needed in deviations more than 15 PD, which has been observed clinically, since most of the less severe cases may resolve with surgery only involving the cyclovertical muscles. This patient with the right congenital superior oblique palsy, a large angle vertical deviation of 35 PD R by L, and a horizontal deviation of 16 PD ET was present. The patient underwent right anterior nasal transpositioning of inferior oblique. This is at 3 months follow-up. The patient is ortho in primary position, does not have a significant horizontal deviation, which has reduced to about 4 to 6 PD, and IO overaction has resolved. Lesson number 6, horizontal near distance disparity matters even in vertical deviation, so that needs to be taken into account. This patient with a left congenital superior oblique palsy with exotropia near more than distance and L by R in primary position, maximum deviation in the dextroversion. So horizontal near distance disparity is an important measurement even in vertical deviations, where we need to target the maximum horizontal deviation, which was near deviation in this case of divergence insufficiency type of exotropia. So it is important to do the horizontal and vertical deviation neutralization in all 9 diagnostic positions of gaze and for near and for distance. So this particular patient underwent LR recession 6 mm, MR resection 4.5 mm, and IO recession 8 mm. At 2.5 years follow-up, this patient is maintaining ortho. Lesson number 7, single muscle surgery might suffice in a lot of cases. It may be successful irrespective of angle of deviation, even in large vertical deviations. So it might be better to operate on only one muscle at a time to ascertain the effect this will have on the ocular motility pattern. Studies have shown that in majority cases, one muscle surgery is sufficient. We allow time to the patient to adapt to the resulting ocular motility and to utilize their extended vertical fusion. But it is important that the patient should be aware that further surgery may be needed. This patient with a left congenital superior oblique palsy with exotropia with DVD, PBCT 55 PD XT and 16 PD LHT underwent single muscle surgery for the vertical deviation, anterior transpositioning of inferior oblique along with horizontal muscle surgery. Lesson number 8, inferior oblique weakening might work most of the time. It has been widely considered as the first surgical option in the treatment of symptomatic SO palsy. So, IO surgery in the form of graded recession, ATIO, ANTIO, myectomy might be considered, especially in cases where there is absence of excessive SO tendon laxity confirmed on Guyton's exaggerated FTT. It is effective in alleviation of ocular deviation and abnormal head posture while avoiding adverse effects with that can happen with other forms of strabismus surgery such as iatrogenic Brown syndrome and overcorrection. This patient with a congenital SO palsy in the left eye with large angle exotropia with grade 3 eye overreaction underwent OSIO recession 10 millimeter along with horizontal muscle surgery. Lesson number 9, look out for masked bilateral superior oblique palsy. Bilateral congenital superior oblique palsy may be overlooked in children in spite of detailed preoperative evaluation, and masked bilaterality should always be kept in mind in cases with unilateral pathology, and patients should be informed about the possibility of bilaterality that might get unmasked in the postoperative period. This patient is a case of bilateral congenital masked superior oblique palsy, the pre-op and the 6 months post-op photograph. So this patient underwent bilateral anterior nasal transpositioning of inferior oblique. The eye overaction has resolved and the V pattern has collapsed. Lesson number 10, anterior nasal transpositioning of inferior oblique works well for large angles and coexisting DVD. We have seen great results in large angle SOPs, SOP with DVD, SOP with missing tendons. Unilateral ANTIO is said to induce asymmetry in up gaze due to anti-elevation syndrome and fullness of the lower lid. But in our experience, even unilateral ANTIO worked well without any of the above drawbacks. This is the case of left congenital superior oblique palsy with DVD with infantile residual esotropia, underwent OS ANTIO along with horizontal muscle surgery, and is maintaining ortho at 3 years follow-up. Thank you.
Thank you. Only for the case 4, I think the case 4 with esotropia, minimal esotropia. So usually in cases of bilateral superior oblique palsy, it may be like undiagnosed bilateral, because in those cases only you will see V pattern esotropia in down and primary. Down may be minimal esophoria in primary position, it could be minimal ET, and in up gaze there will be mild XT. So you will feel like that angle is very less, and that's because angle is very whenever you tackle inferior oblique bilateral, obviously the deviation will go. So usually those cases are more associated with bilateral, and always you have to check for all 9 cases and reversal that you have not mentioned, that in head tilt you have to always see whether there is any reversal of R by L or L by R. That is very important.
Thank you.